Hello and welcome to the Management of Lumbopelvic Conditions course here at Cayuga Medical Center. This course is part of the Orthopedic Physical Therapy Residency and Spine Fellowship Program, as well as a continuing education course. Michael Costello will be narrating the remainder of this presentation, and then you will be learning more information as you come to the live course on Saturday and Sunday. If you have any questions, don't hesitate to reach out to me at kradams@cayugamed.org. I hope you enjoy this course and look forward to meeting you in person soon.
So back pain is a big problem. A study suggests that between 70 and 80% of adults experience a significant episode of low back pain at least one point during their lifetime, and this back pain is likely to affect their ability to perform work or other social responsibilities such as taking care of their family, taking care of friends, being able to do the things that they enjoy to do. During any single year, while estimates vary, at least 7% of the adult population will consult the primary care physician for low back pain, and only routine examinations, high blood pressure, and diabetes resulted in more visits. Certainly, I believe as the physical therapy profession progresses over the next several years, we can change this so that those patients access physical therapy first, as we should be the practitioner of choice for this particular condition. We see back pain frequently in physical therapy. Roughly 25% of all patients in outpatient physical therapy clinics are presenting with a primary complaint of low back pain. This study is from Jetty et al. In 1994. Certainly the data that we see within our residency program is consistent with this. Not only is back pain common, but it is expensive. This is a study by Martin and Deo et al., published in JAMA in 2008. And this was an analysis of healthcare expenditures of U.S. adults, and this looked at those who reported back and neck symptoms. From 1997 to 2005, the cost of care for spinal conditions increased significantly, increasing from $52 billion to roughly $86 billion. Much of these costs were spent on medical consultations, pharmacology, imaging, and surgery. Expenditure for medications increased 423%. Good marketing, big pharma. Each year, about 300,000 Americans have surgery, with costs of roughly at least $10,000 per operation. Spinal fusions, which is one of the highest reimbursed procedures, at about $60,000 per procedure. And with these procedures, we see that this is not significantly better than less expensive conservative care. A study published in 2006, randomized trial comparing likely surgical candidates with groups being randomized to either a standard open discectomy versus a group that received active physical therapy with a home exercise program and non-steroidal anti-inflammatories, which were measured at 6 weeks, 2 months, 6 months, and 1 to 2 year follow-up. we see that particularly the long-term outcomes are not significantly different, especially in terms of work status, satisfaction with symptoms, satisfaction with care. Bodily pain, physical function, and osseous disability index were not significantly different over this time frame. There's a common medical diagnosis of failed back surgery. So the fact that we even need to recognize this as an entity says something in and of itself. Roughly 80,000 new cases of this condition. There's a high reoperation rate for back surgery. And interestingly, with that expensive procedure of lumbar fusions, very few of those patients will ever return to work. With 71 to 95%, depending on the study, never able to return to work. And again, this is in light of no significant long-term difference with conservative care. The famous Gordon Waddell stated, and I quote, "Back surgery has been accused of leaving more tragic human wreckage in its wake than any other operation in history." Again, quite a strong statement. Expenditures for back and neck pain in the U.S. healthcare system are exceeded only by cancer and diabetes management. Has been shown to be a leading cause of missed work, temporary disability, and workers' compensation costs, with the indirect and direct costs being estimated at exceeding $100 billion per year. There are many who believe, Dr. Waddell included, that back pain sort of gets better on its own, with one of the conclusions being a total of 80 to 90% of attacks of low back pain will recover in about 6 weeks, irrespective of the administration or type of treatment. Is this actually true? So looking at low back pain management in general practice, here's a study looking at the proportion of patients who cease to consult with a physician for low back pain after 3 months, and the proportion of patients who reported they were pain-free of low back pain at 3 and 12 months. 59% had only single consultation, and 32 had repeat consultations confined to the 3-month window after the initial consultation. However, of those interviewed at 3 and 12 months, only 21 and 25% respectively had recovered in terms of pain. So it's quite possible that it's not that people recover, but they just stop seeing their doctor because they're dissatisfied with the care that they receive. Again, most individuals will still be experiencing back pain and related disability 1 year after consultation. Thousands of randomized trials and other types of studies have investigated the effectiveness of a variety of conservative and surgical interventions for the management of low back pain. And despite this research, the evidence continues to remain contradictory and inconclusive for many interventions. One possible reason for this is that many of these studies have treated the entity of low back pain as this homogeneous group, whereas in reality something else might be going on. The medical model has historically classified individuals with back pain based on this anatomical model, attempting to identify a source of symptoms at which they can direct the magic bullet. surgery, drugs, etc. However, identifying relevant pathology in patients with back pain is remarkably elusive, and there's several studies out there that suggest that a specific source of symptoms can be identified in only 10% of cases. There's certainly a large focus on things like the intervertebral disc herniation, maybe some sort of fracture or facet dysfunction, infection, etc. Much of this pathoanatomical focus certainly can be traced back to the famous study by Mixner and Barr, who reported on the importance of the intervertebral disc as a possible source of symptoms, where they stated that rupture of the intervertebral disc into the spinal canal is not an uncommon cause of symptoms, and that in reality rupture of the disc is more common than neoplasm. This is certainly true. They also stated that the treatment of this disease is surgical and that the results obtained are satisfactory if compression has not been too long. So if we go back to the study by Martin and Dale et al., here's a list of the ICD-9 codes that were commonly utilized in both 1997 and 2005. And we see a large portion of patients have this sort of unspecified disorders of the back. In other words, we can't identify something specific. And I would argue even in many of the other cases here, intervertebral disorders, and things like that, that just because they have a disc on imaging doesn't mean that that's the absolute cause of their symptoms. Other things to consider, proposed by Dr. John Sarno, who is affiliated with the Rusk Institute of Rehabilitative Medicine at NYU. He certainly focuses on the mental aspect of back pain. And this is a step forward for medicine, recognizing that the mind is actually attached to the body. And there is a plenitude of research that suggests that one's cognitions and emotions and psychological state have a significant impact on back pain and its outcomes. Let's look at risk factors for low back pain. There's a question of genetics, and this may be true for specific disorders, some of the inflammatory conditions or congenital deformities, heredity, maybe. There's some question if the heavier you use your back, if you're a heavy equipment operator, you may be more at greater risk for low back symptoms. There is continuing consistent evidence looking at smoking as being a risk factor for sciatica, as well as obesity. Muscle strength, again, yes, there is incidence or evidence, and certainly in my clinical practice, I've never seen a patient with low back pain whose main problem was that their back was too strong. And again, psychosocial factors. So these psychosocial risk factors are most importantly fear, both fear of injury, fear of pain, fear of re-injury, depression, coping style, particularly a passive coping style, and job satisfaction. In fact, there's more than one study out there indicating for in the occupational low back pain population that job satisfaction or lack thereof is actually one of the #1 predictors of back pain, disability, and return to work. The thing about back pain is that after a single episode, while one may recover from that single episode, potentially in those 4 to 6 weeks, the episode is often recurrent, with recurrence rates reported between 20 and 65%. Oftentimes that recurrence will happen within the next 6 months. So they may feel better 4 weeks later, but 3 months later they're back in the clinic. And again, only 21% pain-free at 1-year follow-up. However, many individuals go on to experience persistent back pain for greater than 6 months. And these are individuals who do not experience episodic low back pain, but more a constant level of low back pain. And for these individuals, only 12% may be pain-free within. So when we look at individuals and we consider, will they keep having problems? Well, a risk factor for recurrent low back pain is that you've, had recurrent low back pain. You've had a history of previous episodes. If your back is more mobile or potentially considered hypermobile, and that could be considered as a risk factor, both spinal specific hypermobility as well as sort of a general hypermobility in the other joints in the body. Risk factors for chronic low back pain, symptoms below the knee, psychological distress, depression, fear, high pain intensity, so high initial pain intensity, and then passive coping styles. Let's take a look at functional anatomy and arthrokinematics. So the lumbar region, specifically, here's a typical lumbar vertebrae. We have these curves of our spine that develop over the course of our lifetime. When we're born, we have this nice C-shaped curve that allows us to fit in the womb. And then as the baby develops, spending that all-important tummy time and looking up, they will develop first the cervical lordosis, as well as some trunk extensor strength. And then as they move forward to standing, they continue on to develop an adequate and important lumbar lordosis, which will allow freedom of movement and shock absorption as they move forward in life. One of the purposes of the spinal curves is that it is this dynamic spring that is able to absorb shock. The straighter the spring, the less able to absorb shock. However, also too much bend is the problem and may not be able to absorb shock as well. So we see that the spine is actually able to withstand up to 10 times body weight. It happens in athletic endeavors such as coming down from a rebound. Here we see Frank Netter's images of the lumbar spine. We have in the top left a vertebral body, or a lumbar vertebrae looking from the top down, where we have the D-shaped vertebral body, the triangular shaped vertebral foramen, the pedicle, transverse process, mammillary process, and spinous process, providing muscle attachments, and the facet joints. A single spinal segment is considered to be one vertebrae stacked on top of another, and all of its related structures, including the disc, ligaments, nerves, muscles, vasculature, etc. When we look at the vertebrae from a lateral view, we can see the intervertebral foramen, which are actually formed as one vertebrae comes together. Here we see a radiographic view, an AP view, where you can see the separation of the vertebral bodies, which is where the lumbar disc resides. You can see the transverse processes faintly. In this lateral view, again, we can see the space between the vertebrae where the lumbar disc is. We can view the neuroforamen. You can see at least part of the pedicle. Ideally, the intervertebral space should get progressively wider as you move from superior to inferior. We can see in this particular individual that the disc space at L5-S1 is slightly narrower than this space at L4-5. This may be an indication of some wear and tear on that L5-S1 disc. Here we have an image depicting how the spinal nerve roots exit the spine. We have the cervical nerve roots exit above their named level. So C4 nerve root exits above C4. Just because anatomists wanted to keep you on your toes, even though there's only 7 cervical vertebrae, there are 8 cervical nerve roots, with C7 exiting above C7 and C8 exiting below C7, which means from there down, the named nerve root exits below its related vertebral level. We see the thoracic and lumbar roots exiting below. Spinal cord, solid spinal cord ends at approximately the T12-L1 region, give or take a level or two in each individual. And from there down is the cauda equina, or the horse's tail, which is where the nerve roots are free in the inferior portion of the spinal canal. Here we have one of Campanji's pictorial depictions of the vertebral body, where we have the anterior column comprised of the vertebral bodies, and then the posterior column, which is comprised of what is sometimes called the articular pillars, or essentially where the facet joints are. And this is this three-legged stool. The three-legged stool has a particularly large leg in the front with 2 small legs in the back and the lumbar spine. The trabecular bone in the vertebral body is very well organized into these vertical and organization with horizontal pieces that come across, sometimes called struts and crossbeams, if you think about the architecture of a building, for example. And this is somewhat different than the trabecular bone of something like the iliac crest, which tends to be less organized. This is related to how forces are generated through these particular bones. Through most of the lumbar spine, every muscle that acts on the vertebral column is attached somewhere on the posterior elements or the lamina. whereas only the crura of the diaphragm and parts of the psoas muscle attach to the anterior portion of the spine onto the vertebral bodies. There are certain ossification centers of the spine. So here's an interlaminar ossification center depicted on the left side. You do see on the right, based on how the architecture, if you will, of the spine, you have lines of force that can be transmitted directly horizontally across the pedicle. And then there's this oblique angle of forces that come across, and they cross pretty much right near the pedicle and facet joints. And this is an area of significant stress. So in young athletes, when the spine is undergoing a significant amount of growth and remodeling, again, it's important to remember that full maturation doesn't actually occur until approximately the age of 25, that these numerous ossification centers leave the posterior elements with points of weakness that are susceptible to injury with repeated stresses. So all of our little tykes doing backward bending, while they're having fun, they are applying stress to particularly their posterior elements and that extreme range of hyperextension. Again, this is not something necessarily bad to do, but too much of a good thing can be a problem. There's some study suggesting that certain individuals may be predisposed to injury regarding what their structure is like. So on the left-hand side of your screen, you see what is considered normal architecture, where you see the interfacet distance progressively increase as you move from superior to inferior, sort of looking like the Eiffel Tower. Whereas on the right, you don't see that steady increase as you move inferiorly. The interfacet distance is relatively similar from superior to inferior. And these individuals are predisposed and have demonstrated a higher incidence of fatigue stress fractures such as spondylolisthesis. The intervertebral joints, or facet joints. This is the synovial joints. So like all synovial joints, we have a joint space, articular cartilage, synovial membrane, synovial fluid, a joint capsule, ligaments, and articular discs within that synovial joint. The joint is highly innervated, and just like any other synovial joint, it can work very well. However, it can also be susceptible to degeneration and arthritic changes, which can rise to certain types of symptoms. Here, for example, is, I believe, a CT scan looking at the facet joint degeneration with significant degeneration on the left side of your screen. Loss of joint space, loss of joint integrity. Just a picture from Stanley Paris. So this is doctoral work investigating the structure of the facet joint. And there are these meniscoid structures, both at the superior and inferior aspects of the facet joint. And the purpose of these meniscoid structures are to essentially, again, guide motion and also keep the facet joint from getting nipped, if you will, as the facet surfaces slide up and down. These meniscoids, it is hypothesized, can become entrapped and inflamed, and can be part of what contributes to facet joint dysfunction. We also see from this picture the spinal nerve root, which exits relatively superiorly and within the intervertebral foramen. We've actually got a large amount of extra space in the neural foramen, which allows the nerve root the ability to move and adapt to changes in tension, compression, as well as anatomical changes that may happen over time. And with all joints, facet joint health is maintained by the cyclic compression and decompression that happens with activities of daily living. Just like we tell our patients, motion is indeed lotion. The interbody joints, which is where we have this intervertebral disc, primarily in anatomic position. We have more pressure anteriorly, or more pressure posteriorly, which is going to push the nucleus in a more anterior position. These days we have lots of research going into developing an artificial disc, and while for some patients artificial disc surgery can be very beneficial, still this artificial disc is not nearly as good as the original. Look a little more deeply at the structure of the intervertebral disc to review. We have the fibrous outside of the annulus fibrosus and the nucleus pulposus on the inside, the posterior longitudinal ligament, separating the disc from the vertebral canal. We have this porous end plate. We have several lamina or layers of the nucleus, of the annulus fibrosus, and these fibers are oriented in alternating angles to each other. And then we have the very wide anterior longitudinal ligament on the front of the anterior, on the anterior portion of the vertebral bodies. If we look at the vertebral disc working from out to in, we have this neurovascular capsule, so this is innervated and vascularized. You will see throughout anatomy that oftentimes nerves and blood vessels run together. This outermost layer connects the anterior and is connected to the anterior and posterior longitudinal ligament. It's comprised with Sharpie fibers that firmly attach the annular rings to the vertebral bodies. And tension along these fibers related to excessive mobility can create traction spurs, which you will see as scalloping on radiographs. The outer fibrous annulus is primarily type 1 collagen, which is going to resist tension. You have this oblique orientation of fibers, and importantly, only 50% of fibers can resist rotation in any particular direction. We do commonly see disc injuries. Their mode of injury is oftentimes a rotary action. The inner, sort of less fibrous annulus is the transition from type 1 to type 2 fibers, so looking at resisting both tension and compression. And it's much less organized than the outer fibers, and it's really meant to address stress in multiple directions. The nucleus pulposus is comprised mostly of type 2 collagen fibers, which will resist compression, and it's a very hydrophilic structure. while contained within the fibrous annulus, that hydrophilic structure creates this outward pressure, sort of like the air pressure within a bike tire. Once that that nucleus propulsus escapes the container of the annulus in some sort of disc rupture, that hydrophilic structure can expand to approximately 3 times its original size. Importantly, we also have the cartilaginous end plate, which is this permeable membrane, if you will, between the vertebral body and the disc. And it is this porous structure that allows nutrition to diffuse across from the vertebral body, where there's a lot of blood flow, into the center of the disc, which is really essentially avascular in a normal healthy disc. And this imbibing of fluid in and out through differences in posture is, again, what brings nutrition to the disc. I tell my patients that the disc is like a large sponge sitting in water. So when you lie down, you draw in water to the sponge, and the sponge swells up, and as you are vertical during the day, you're gradually squeezing water out of the sponge. Here's a picture of an intervertebral disc, and while many of us learned in anatomy classes that it was like a jelly donut, I've had several researchers say to me it looks more like a undercooked scallop. With different motions, as mentioned before, the changing pressures will push the gelatinous nucleus propulsus around, so backward bending will create tension anteriorly on the anterior annular fibers, compression posteriorly, and that will push the disc in a more anterior direction. Forward bending will do the opposite, where you have tension on the posterior fibers, compression on the anterior fibers, and the disc being pushed in a more posterior direction. You can see the concept with lateral bending. If you bend to the right, you've got compression on the right, tension on the left, and the disc will move more to the left. Rotation is this torsional movement, so you actually have a compressive component with rotation. So again, with a lot of rotary sports such as golf, cricket, baseball, we do see a high incidence of disc-related or potentially disc-related pathology. Here's the graph from the famous study by Nachemson et al., where he took his 4 medical residents, placed instruments to measure intradiscal pressure with different positions. We do see lying supine is a position where there's the least amount of pressure on the disc, and slumped forward holding weights is one of the positions where there's the greatest amount. We can use this information to relate the amount of positions and pressures and exercises to the amount of intradiscal pressure. However, we also don't want to use this to induce fear in our patients. Rowers who do a combination of essentially sitting slumped forward with a fair amount of resistance attached to their arms do have a high incidence of low back pain and, again, disc-related pathology. Here's the famous MRI, which demonstrates on your left-hand side of the screen 2 herniations at L4-5 and L5-S1 with an extrusion of disc, with the disc material pressing out posteriorly. You can actually see the posterior longitudinal ligament being pulled away from the vertebral bodies as the disc material pushes more posteriorly. On the right-hand side of the screen, you see a very central disc herniation, focal disc herniation. However, it's interesting, you can see the nerve roots in the cauda equina are actually able to move out of the way, if you will. So there's also several other ligaments to consider. We have supraspinous ligaments and intraspinous ligaments. We have intertransverse process ligaments or intertransversary ligaments. We also have a strong ligamentous structure attaching particularly the most inferior lumbar segments to the pelvis. In men, there is an iliolumbar ligament attached from both L5 as well as L4. Whereas in most women, the attachment from L4 to the pelvis doesn't exist. This lack of ligamentous attachment allows greater mobility for women, which is needed most importantly in childbirth, but may also predispose women to conditions related to hypermobility. The sacrum sits as the keystone within an arch. And the arch is actually a very strong structure. The weight from above is distributed across the arch to the pillars on either side. And just as we see this in the picture of the arch to your left, the weight of the upper body is distributed across the keystone of the sacrum to the pelvis and the pillars of the legs. It's important to remember that the vertebral column is capable of a wide range of movements that can often be graceful and fluid, and that these structures really are capable of moving through potentially a wide range of motion. As one bends forward, you're going to have stretch and lengthening through the posterior ligaments and ligamentum flavum. And as you move into back bend, you will have significant stretch along the anterior longitudinal ligaments. These ligaments are highly innervated, particularly with proprioceptive receptors, and so this is why we see impaired balance in individuals with back pain, where they may have impairments of these ligaments. So this is admittedly a relatively small study, where we see individuals with chronic back pain compared to age-matched controls performing postural tasks. And there was a much larger amount of postural sway in the individuals with chronic low back pain as opposed to those healthy subjects. There are several muscle layers that surround the spine. Anatomists will divide these in many different ways, but one can consider 4 layers. The outer layer being the trapezius, latissimus dorsi, and thoracolumbar fascia. The second layer being the levator scapula, major and minor rhomboids. The deep layer being the erector spinae, semispinalis, spinalis longissimus, and intercostalis. And then the deepest layer being the multifidae, rotores, and intertransversarii. Here's another anatomical picture dividing things in primarily 3 layers. The website below here from the University of Wisconsin is actually an excellent website for an anatomy review. There's a statement from Phil Greenman, a famous manual medicine practitioner and teacher at the at Michigan State University in the Osteopathic Manual Medicine Department. At the fourth layer muscles of the multifidi and rotaries and intertransversi serve more as proprioceptors than prime movers. When dysfunctional, they may alter joint mechanics locally and alter the behavior of the larger muscles of the erector spinae group. I've heard some people say that the deep layer act more as active ligaments, if you will. And they hypothesize that certain types of spinal dysfunction may be related to, for example here, a hypertonic deep muscle on the right, holding a vertebral level in a right side bend position, holding the facet joint closed on one side, limiting the ability for this segment to, for example, bend to the left. The multifidi actually has different types of fascicles, some that arise from the lamina and insert onto the mammillary process. And then you have these overlapping groups that rise progressively up from the sacrum and move superior medially to attach to the mammillary process. Here's a depiction of these different layers. So attaching to the mammillary process and spinous process, so the deepest part of the spinous process. Again, many people consider that the multifidus is not a primary rotator, but again, rather a stabilizer. It does not have a very large lever arm to create rotation. Rather, many people will consider that these create a bowstring effect to support the curve of the lumbar lordosis. Some of the deep fibers of the multifidi importantly attach to the capsule of the facet joints. And this attachment allows the multifidus to protect the joint capsule from being caught during joint movement. So for example, as a facet joint closes, it's possible that if the facet capsule was not moved out of the way, that the capsule would be pinched, if you will, as the facet joint closes. The multifidi may pull this out of the way. There are certain types of manual therapy techniques that use this concept to free the facet joint. This sort of is related to how the rotator cuff fine-tunes and controls the movement of the glenohumeral joint to keep the head of the humerus centered in the socket and prevent other structures from being pinched. It's a very similar concept. The famous transversus abdominis has a very wide attachment along the lateral third of the inguinal ligament, the iliac crest, cartilages of the lower 6 ribs. It's attached to the diaphragm and the lumbodorsal fascia, and wrapping around anteriorly to attach to the crest of the pubis, the pectineal line, the linea alba, and the aponeurosis of the internal oblique. We consider particularly that attachment to the linea alba if you see an individual with a rectus diastae, whether it's a woman who, for example, was pregnant or recently pregnant, or particularly that older gentleman who oftentimes present with rectus diastae. That means that essentially their transverse abdominis is separated and may impair the function of the muscle. So the transverse abdominis connected to the multifidi posteriorly and the thoracolumbar fascia is to create this continuous ring around the spine, which as it contracts and squeezes that ring increases the intra-abdominal pressure, and that is part of what supports the lumbar spine, particularly in conjunction with the bowstring created by the multifidi. Some researchers will discuss this concept of postural and phasic muscles, which are essentially opposing muscle groups, and that abnormal firing in one group may result in tightness and pseudo-weakness in the other group. These agonist and antagonist relationships were described by Vladimir Janda, a physical medicine practitioner from Czechoslovakia. He described postural muscles being the iliopsoas, tensor fasciae lata, hamstrings, abductors, gastrocs, erector spinae, piriformis, and quadratus lumborum. And phasic muscles being the glute maximus, quadriceps, glute medius, anterior tibialis, rectus abdominis, rotators, and obliques. His general concept was that postural muscles had a tendency to become tight, and phasic muscles had a tendency to become weak. For all of these considerations, it's important to recognize that all movement is dictated by this interaction between the muscles, joints of the body, and ligaments. The joints and ligaments will provide the architectural structure and, in one sense, determine what movements are possible, whereas the muscles will determine what movements actually are able to happen. Let's talk about pain generators. And I will say here, this is input. So the pain is not in the vertebral disc, but the vertebral disc, for example, may provide input into the nervous system, which will then have to be processed by the brain. For those of you in the full residency program, we will talk about this somewhat more in this course, but certainly more in the pain sciences course in August, or in April. So certainly the intervertebral disc can be a source of symptoms. As mentioned before, in a healthy disc, only the outer annulus is innervated, and normally the inner portion of the disc is actually avascular and aneural. However, in a degenerated disc, we see that the inner part of the disc also becomes innervated and somewhat vascularized, and therefore can be a generator, a pain generator, an input generator. The facet joints, again, highly innervated. They have multi-level innervation. Again, Stanley Paris's doctoral work demonstrated that the lumbar facet joints oftentimes are innervated by 3 levels. Oftentimes the facet joint is innervated by nerves from the segment level itself, as well as levels above and below. The sacroiliac joints. While the sacroiliac joints are an area of much debate, they are certainly innervated, and they do have a certain amount of movement. While it is not a large amount of movement, it is an important amount of movement that allows shock absorption. And it is innervated and can be a potential source of input. The facet joints are innervated by the sacral nerves, as well as at least L4 and L5 nerve roots. The paraspinal musculature. Again, the muscles themselves can be a problem, either through weakness, tightness, trigger points, etc. The ligaments, like any ligament, can be sprained, strained, pulled, torn, ruptured, etc., etc. And the fascia, which envelops the entire body. There's a continually emerging body of research looking at innervation of fascia, proprioceptive input from fascia, and even the how the fascia relates to immune function. Bone obviously can be a pain generator. Anyone who's broken a bone knows this very well. And here we see all these different structures. Let's look at arthrokinematics, or the specific movements of joints. How do these bones actually move? It's important to remember that knowledge of arthrokinematics may influence your decision making and inform which technique you choose and how you perform the technique. It's also something to consider when listening to someone's mode of injury. Again, that spinal segment is comprised of two vertebrae, one on top of the other, the disc, facet joints, ligaments, muscles, blood vessels, neural structures. See from one of Saunders' textbooks, this idea of rotation, side bending, and forward and backward bending. With all these, you have a certain amount of gliding and translation, compression and distraction as you move in different directions. As you will see, much of the movements in the spine are oftentimes combined movements. So you really have all of these compression, distraction, gliding, translating happening in different directions. So let's look at forward bending. So as a lumbar vertebral segment moves into forward bending, the vertebrae sort of rocks over the nucleus. Both facet joints will slide up, or sometimes called opening. The anterior disc is loaded, and there is somewhat bulging anteriorly as you have compression anteriorly. The posterior disc is posterior fibers of the annulus fibrosus are drawn taut, and the vertebral foramen enlarges vertically. As the lumbar spine goes into backward bending, again the vertebrae rocks over the nucleus, the facet joints slide down and back, or close, and eventually may actually contact the inferior lamina. The posterior disc is loaded and may actually bulge, whereas there is tension on particularly the outermost fibers of the anterior disc. The superior vertebrae actually translates somewhat posterior. The intervertebral foramen closes, and at extremes of backward bend, eventually the facets become a fulcrum and the disc space is distracted. The facet capsule is stretched. If we look at right side bending, essentially the facet joint on the right side slides down or closes, the left facet joint opens up, the disc will bulge on the right as there's a certain amount of compression, and the outermost fibers will tension on the left. The nucleus of the disc will slide somewhat to the left. The right intervertebral foramen will close and the left intervertebral foramen will open. And as far as rotation concerns, there's a considerable amount of debate. You will see both descriptions of rotation to the ipsilateral side as well as to the contralateral side. essentially some of what determines the rotate to the contralateral or ipsilateral side may depend on which position you start from before you move into side bend. Many will consider if you start in sort of an anatomically neutral position as you move into side bend right, you will have a component of contralateral rotation, so rotation to the left, whereas if you start in either forward or backward bend from neutral, you may be more likely to have ipsilateral rotation, so that if you if you side bend to your right, you will also rotate to your right. Let's look at rotation. So if we look at rotation to the left, as one rotates to the left, the right facet essentially becomes a fulcrum. It gets compressed. The vertebrae will translate to the left. The left facet will actually distract or gap. The disc is compressed as a result of torque, and the left interval foramen will open up as the facet joint is gapped. Again, this concept of coupled motions, oftentimes side bend and rotation recur together. There's this concept of Fayette's laws and type 1 and type 2 motion, where essentially type 1 motion being side bend and rotation occurring to the opposite direction, and whereas type 2 mechanics are side bend and rotation occurring to the same side. Again, in the lumbar and particularly the mid and lower thoracic spine, both types of movement may occur depending on which position you start from. This concludes our review of epidemiology, anatomy, and arthrokinematics. Again, if you have questions, we'll be happy to review these at the beginning of the class. I encourage you to review the readings that are mentioned, that are recommended. And I hope you enjoyed this. Thank you.